first talk, that is optimizing Phaco incisions to minimize astigmatism. So this is how it all began, and there's no financial interest in any of these techniques mentioned. So let's look at the historical perspective. The first steps were incision optimization. This is what we had. The only tool we had was how to use the incision to minimize the astigmatism which is present. There were no toric lenses. LRIs also came in a little later. So there are essentially a few parameters which can be modulated to optimize the incision. One is first is incision axis. At which axis you're placing it, the size of the incision, and the incision placement, whether it's anterior or posterior. As you'll see, more anterior the incision, greater the induced astigmatism. Then came astigmatic keratotomy. It was a powerful but erratic tools. Then relaxing incisions, which moved posteriorly in the form of peripheral corneal relaxing incisions and limbal relaxing incisions. Dr. Bharti will be talking about it. Then came the opposite clear corneal incisions, which is a logical fallout for the cataract surgeon, where essentially two clear corneal tunnels 180 degrees apart are made on the steeper meridians, and there's no additional instrument requirement or skill required. But of course we have to take early post-operative care because there are two penetrating wounds in the cornea. Then toric IOLs have come in for quite some time now, and they have been refined further, and they're probably the most elegant and scientific way, although the downside is it adds to the cost of the surgery. So astigmatism, disclaimer here that astigmatism control is still not an exact science. We're all learning, and one of the biggest bugbears here is the wound healing factor, which can make the results unpredictable. So let's look, before we go on to understanding, let's look at, for the benefit of all the speakers in the course, we'll look at the basic concepts and terminology. So there are certain astigmatism control parameters, like the size of the incision. We'll look at each of this in a little more detail. Distance from center of the cornea, axis of incision, the coupling effect, and wound healing, which is the biggest variable. So please note, astigmatism is a vector quantity. That is, it has both a magnitude and a direction. Magnitude is measured in terms of diameters of cylinder, and direction is measured in terms of axis in degrees. Surgically induced astigmatism is the astigmatism, with commonly used abbreviation is SIA, is the astigmatism resulting from a surgical procedure and can be used to effectively reduce pre-existing cylinder. So as the size of the incision increases, you see here in the schematic, the size of the incision increases, the greater is the relaxation of the tissue, and therefore induced wound slippage, and therefore more induced astigmatism or SIA. Now coming to the next parameter, the distance from the center of the cornea. Closer the incision to the center of the cornea, greater is the induced astigmatism. In this schematic you see that this is the temporal cornea, and we know that the distance of the temporal cornea from the center of the cornea is, distance of the temporal limbus is more, and therefore the incision made on the temporal limbus will have lesser astigmatism compared to the superior one where the distance is less. And therefore the SIA therefore temporal, as you know, is the preferred site of incision for most surgeons, because the reason being that the distance is more, so the induced astigmatism is less. Coming to the next parameter, the axis of incisions. The incisions flatten the meridian they are placed on, and this fact is taken advantage of in corneal incision surgeries, where the aim is to flatten the steeper meridian. This could be by the means of a tunnel or clear corneal tunnels, two opposite ones, and the relaxing incisions. Corneal tunnel can be made temporally or on the steeper meridian. When it is called, when we do on the steeper meridian, it's called an on-axis phacoemulsification. So the next important parameter is the coupling effect. What it essentially means is the modification of one radius of curvature results in an opposite and equal effect on the radius of curvature 90 degrees away. That means if this is a steeper meridian in the cornea, and an incision on this would therefore flatten this steeper meridian relatively and steepen the flatter meridian. So it's an opposite and equal effect on an axis which is 90 degrees away. Another important concept is surgically induced astigmatism. This looks very confusing over here, all the trigonometry involved. So surgically induced astigmatism is the astigmatism developing as a direct result of the procedure performed, and it is calculated by vector analysis. Fortunately, we don't have to learn all this, and there are very nice calculators which are available online, which we can go on to. The initial ones were Dr. Higgis, Dr. Hill, Dr. Saurabh Chaudhary, Alcon, and all the companies have it. And I would suggest that you play around with these, even if you want to move on to toric IOLs, or if you're already doing toric IOLs, to understand astigmatism. You can play around with these, have your own values, have your own patient's values, or even some imaginary values to understand how astigmatism works. A quick look here on one of the calculators, how to go about it. It's a very simple thing. This is the pre-op, can you read it? Pre-op keratometry, post-op keratometry, the individual SIA. So pre-op is the 44 is the steeper, flatter meridian 44 at 90 and 45 at 180. The resultant post-op keratometry after maybe 4 or 5 weeks is 44.25 at 80. We know that sometimes axis can shift, even if we've made an on-axis surgery, and 44.75. And you get a value of 0.56 is the SIA at 99 degrees. Supposing I were to change it to, in the post-op to 44.5, and just see how the value changes. From 0.56, it will go to 0.77. So this is how one can, understand this and help move ahead. So these are some of the online toric calculators available. There are quite a few now. Wound healing, the last factor, is still not very well understood, and drugs may modify healing to some extent. You can take advantage of topical steroids to control the astigmatism to some extent, but it's not very predictable. So coming specifically to on-axis phacoemulsification, the principle is we try to flatten the steeper meridian, and the axis or the orientation is the incision is placed on the steeper meridian if pre-op astigmatism is more than or equal to 0.5. I would recommend if it's less than 0.5, supposing it's 0.25, 0.3, 0.4, then go with a temporal incision. It's simply because that induces the minimum astigmatism, and astigmatism less than 0.4 is quite tolerable. But if it's more than 0.5, you can either go on to a steeper meridian or consider a toric IOL. Pre-op astigmatism, as I said, less than 0.5, a temporal clear corneal incision is preferable. Placement is usually clear corneal, but one can move the incision anteriorly or posteriorly to either increase or decrease the induced astigmatism. Size now, initially early days when we were doing PMA lenses and there was patients with a lot of astigmatism, we would increase the incision and put in a 5.5 or a 5 mm lens. But those days are gone. One, it makes this wound very unstable and it's not recommended anymore, and we have better ways of doing things. So now usually we don't go up to more than 2.8 millimeters, especially if it's a temporal clear corneal. And posterior limbal and scleral incisions, of course, if you made a scleral incision, it can be made longer because they are inherently more stable. Coming to opposite clear corneal incisions, these are two standard Phaco incisions or tunnels made 180 degrees apart along the steeper meridian. The advantage is that no additional surgical skill or instrumentation is required, and the instruments that are used for clear corneal incisions can be used for OCCI also. But please note, OCCI penetrating, so you have two penetrating wounds of almost ranging between 2 to 2.8 each, and they require careful early post-operative care, and you should ensure that the AC has not flattened out in the next post-op day. Pre-operative workup, the inclusion criteria is as like for any cataract surgery should be properly screened. Astigmatism of up to 1.25 diopters, and here I'd like to make a mention here that the tolerance is a little more with the rule astigmatism. For instance, with the rule astigmatism, it's the superior meridian is steeper, and the incision can be placed closer to the center, so you can correct more. Also, there's the concept of posterior corneal astigmatism, which I think Dr. Purend you'll be talking about when toric IOLs, no? Yeah. So that also helps in reducing this. And against the rule astigmatism, I would be able to correct much less, and therefore, as I said, tolerance is less for against the rule. Workup is for a routine cataract surgery, and the axis of astigmatism is to be noted. On the specific procedure, reference marks are made in the horizontal meridian in the sitting position, like for any toric IOL or toric ICL. On table, what we do is the steeper meridian is marked using an axis marker. Now, if you're doing an on-axis phacoemulsification as opposed to a toric IOL implantation, there's a little more room for leeway for, you don't have to be so precise, because you're trying to just improve the results and not because you're trying to implant a toric IOL at a particular alignment. Incisions could be clear corneal, limbal, posterior limbal, depending on the pre-existing astigmatism. And just note that if you're doing a posterior limbal incision, due to the egress of fluid, there can be ballooning of conjunctiva. I'd like to give a small tip here, because if you see sometimes the conjunctiva just balloons up, so you should just do a localized conjunctival peritomy just behind the incision so that the fluid does not accumulate over there, and you can proceed with surgery. Proceed with phaco surgery as usual, and you may increase the size of the incision before or after IOL implantation. But now it is not recommended to go beyond, I would say, even 3 millimeters, especially if it's a temporal clear corneal incision. OCCI, the steps are the same. This is till IOL implantation, and then with viscoelastic in the AC, OCCI is made 180 degrees opposite to the main incision. Note the same principles of size, placement and axis of incision would apply to OCCI too. Irrigation and aspiration is done and recommended. Once you've done an irrigation aspiration, I would recommend to hydrate the OCCI wound because it tends to leak. Unlike the main tunnel wound where you put in the probe so many times and there's been hydration and egress of fluid, which tends to seal better, and this the OCCI wound tends to leak, so you should hydrate it well. Post-operative follow-up is a routine post-op phacoemulsification follow-up. In addition, careful observation of astigmatism should be done. This is the typical instrumentation, the axis marker, the reference marker. Few short video clips I'd like to show, just to highlight. So, the reason for sitting and marking is because there's cyclotorsion. But even if you've forgotten to do that or you haven't done that and there's a small astigmatism and you want to correct, on the table also you can do it. So here we'd marked it initially and we're doing it at 175. So just one incision. Now, unlike toric where you need on both sides, we are not implanting a lens, toric IOL here, and you can just make the incision. Going to the next. Sometimes now, I don't even mark, I have an approximate idea of where the incision is, where the axis would be, and in this case, for instance, I wanted 170 degrees. I had a mental picture and I went ahead because we are not being very precise like a toric IOL implantation. So it's not that if you haven't marked, you can't do it. If you know the axis, so important is to do an accurate keratometry. Then the tip that I gave you about ballooning of the conjunctiva, if you're going a little posterior limbal or scleral, you see I've got posterior almost, it's a little between posterior limbal and scleral. So I've made the incision, and now if I continue with phaco, this conjunctiva will balloon up. So that's the tip I gave. Just do a little peritomy around that. This area is clear and you'll be comfortable during the surgery. OCCI, very simple, nothing to really understand here. It's just essentially a phaco tunnel. If you're beginning, of course, it would be an unusual position if you're a beginner, but very soon you get used to it. So this was the original incision, just making another clear corneal incision, opposite clear corneal incision. As I said, hydrate this. We hydrate this, but this is looking hydrated. Can you see this is looking hydrated? But if you don't hydrate this opposite clear corneal incision, it's going to leak. Coming to literature, there's a lot of literature on comparing on-axis and temporal incisions and on OCCIs. So there's a plethora of studies, but the results are often not comparable because of different evaluation and analysis techniques. Certain facts do emerge, however, that in temporal versus superior incisions, lesser induced astigmatism is present with temporal incisions, which is, as we already understood now, why. And in temporal versus on-axis, astigmatism correction is more with on-axis in most studies, and it is statistically significant in some studies. OCCI enhances the astigmatism correction. There's a suggested algorithm if you're beginning out, but you have to develop your own. This is what I follow. Less than 0.5 diopters of astigmatism, go with a temporal incision. More than or equal to 0.5, I would do an on-axis phacoemulsification. The temporal correction achievable with a 3 mm, I've taken neither 2.8 or 3.2, a 3 mm incision is about 0.25 diopters in a temporal correction. You could probably go up to 0.5, pushing the incision anterior. You can increase by increasing the size or moving incisions anteriorly, as I said, up to 0.5. Superior incisions, you can correct up to 0.75 diopters. OCCIs will give you an additional 0.5 to 0.75 diopters depending on the parameters used. So on-axis phacoemulsification, we are not very aggressive now because of unstable wounds. We don't want to increase the size of the wound too much. At the most, if you can place the axis, we get away with it, it's fine. Or you make the wound a little anterior, but I would not want to increase the size of the incision now because there's unstable wounds, risk of endophthalmitis, and we have better and more specific methods like toric IOL available. Opposite clear corneal incisions, again a valuable tool to enhance astigmatism correction. A simple low-cost method done in the same sitting with just one additional step. However, a simple restraint of over-aggressiveness needs to be applied. In conclusion, on-phacoemulsification and OCCI are good options to deal with mild to moderate astigmatism up to 1.25 diopters. We are not very aggressive now with other good options available. We need to get familiar with the SIA calculator, and exact axis measurement is very essential, and we should develop one's own nomogram. Thank you for a patient hearing.